So I am, for those of you who don't know, I am a nurse. I have my bachelor's in nursing, my master's in public health, and my doctorate in medical anthropology. And throughout my career, I have been working primarily in maternal child. I worked with the National Children's Study, as Bree just mentioned, and I've been working with Charm Echo, and I work in a number of community projects, all addressing aspects of maternal child health. So today what I'm going to present is I was working with the IHI Merck program for mothers in association with Henry Ford Health System, and we were trying to figure out what we could do to reduce maternal mortality and maternal morbidity. And I was with the postpartum group, and we looked at the high risk factors that affect women, and why is it that we see African American women far more likely to come in with severe maternal morbidity and unfortunately much higher rates of mortality. So we decided that it was probably important to talk to moms. So this portion of my presentation is the perception and perspective of African mothers, postpartum anticipatory guidance, needs, and care. We have the next slide, please. So just as a background, in 2018, ACOG came out with, they had an opinion on optimizing postpartum care, and they said we needed anticipatory guidance. The providers needed to anticipate what mom would need during her pregnancy and postpartum period. And highlighted in this opinion was the importance that care that is delivered has to be both individualized and woman-centered. And you may not be aware, but as many as 40% of women do not attend a postpartum visit, and many are not prepared for the types of physical, social, emotional, and medical issues that confront them in the postpartum period. So in order to provide care that is acceptable and utilized, we decided that a determination had to be ascertained as to why women don't follow up for postpartum care and what they perceive as their actual needs, not only during postpartum, but during pregnancy and delivery as well. Next slide. So African American women, as I mentioned, are 2 to 4 times more likely to experience pregnancy-related severe morbidity and mortality than are white mothers in the United States. And half of the pregnancy-related mortality has been judged to be preventable. And many of the conditions that lead to severe morbidity develop across the life course. However, access to quality care can be problematic for African American women. Social determinants of health, which are impacted by structural racism and negative experiences in the healthcare setting, play a role in the elevated maternal death rate. And while anticipatory guidance is promoted to prepare women prenatally for the postpartum period, African American women routinely report a lack of respect and culturally inappropriate interactions with their healthcare providers. So to reduce the risk of preventable negative outcomes, the design of care that is acceptable, individualized, and well received requires the input of those who are best able to articulate those needs, and those are the African American mothers. So for our study, we selected African American mothers who were participants in the ECHO and who gave permission to, in the CHARM, and who gave permission to be contacted for future research. And these were women who had delivered in the past 1 or 2 years. We sent information by U.S. mail, an informed consent, not an informed consent, an information sheet, and information about focus groups that were coming up or interviews. Then we had a series of 3 focus groups plus 10 additional individual recorded interviews after the pandemic began. And these were conducted with mothers to elicit their input on their experiences during their prenatal, interpartum, and postpartum period, and their knowledge of warning signs and respectful care. These narratives were then transcribed and reviewed for thematic analysis, explanatory models, and knowledge and concepts of risk. Next slide. So I'm going to give you just a kind of a smattering of some of the responses that we got from moms, because we were searching to find out what they could tell us. So one of the questions is, why do women get prenatal care? And overwhelmingly, what moms said was, it was so that they can know what's going on when they're healthy. We get prenatal care to help the baby, because, you know, they give us pills that help the baby to grow, and certain things our body might not be or can't help, we can't help with, or we might not be eating right. So the moms were looking specifically at, their responses specifically had to do with helping the baby during their prenatal care. Next slide, please. So we asked for the challenges to getting prenatal care, which is an ongoing problem that we hear from moms, the first answer here is that I have listed and highlighted is that there's no transportation or a lack of insurance, and it's hard to find a free clinic if you don't have insurance. And these were repeated multiple times from women we spoke with. Next slide, please. During your pregnancy, what were your primary concerns? So routinely, it was I wanted to make sure the baby was okay. And in this highlight session, it said, so with both my babies, because I was a premature baby, I was born 2 months early, so I was scared. I didn't want my babies to be premature. So I tried to eat healthy. There are things that I just stopped doing so they could grow right. My babies were always on my mind. And you see in parentheses below, I said all the moms' answers primarily focused on their babies and not on themselves. Next. During your hospital stay, what was most helpful in preparing you to go home with your baby? And we were concerned that when the women came in the hospital, because it's such a whirlwind event in the hospital, it's very, very short. What helped you in preparing you to go home? Some of our mothers were new moms, for the first time moms, and others had had children before. But a couple of responses here that I've highlighted. I left the hospital because I did not like the way I was treated. I was not listened to. When I told the nurse the baby was coming and she said, sit still for the epidural, when they tried to put in the needle for the epidural, I fell back on it and the baby came. Another is that it was like an assembly line. There was nothing special. Nothing was done one-to-one. They don't offer water births downtown. You want these moments to be, you want these moments to be beautiful, and they dismiss you. And this last one, I don't have it highlighted, but I missed the experience of seeing my baby being born. They put me to sleep for a C-section. You'll notice I'm kind of jumping around, but there wasn't a lot that was said about what was really helpful for them. One said they had a video, you had to watch it. Okay, so next slide. During your hospital stay, what was most helpful? Another one was here, and this was a woman who had a very good experience. She had an experience that was not in the metropolitan Detroit area. She ended up being out of the city and had a delivery at a different hospital, and she talked at length about how they made her feel wanted. And she said she didn't have a hard pregnancy, but they were always there for me. Anytime I turned around, whatever I needed, they were there. Like I had one nurse who sat and talked to me, and I had questions. Why is this? Why is that? She talked to me about everything. And they even received a card in the mail with all the nurses who had signed the card. So this was a different experience from some of the ones that we were having more routinely from our moms. Next slide. And where you taught about warning signs. Obviously, women, the severe morbidity and mortality occurs generally during the birth or during that critical period postpartum. So we wanted to know, what were they told when they were sent home about what to look out for? And the first answer I have here, the one that's not highlighted, says just charged with a paper that had things highlighted, and they told me to call. They didn't say much about caring for yourself. They just wanted to check the car seat. You see people who bring you food, bring you your food more than you see your nurse. Next slide, please. So I asked the moms, and many of them said they were not aware of this, but I asked them, why do you think it is that African-American women are 2 to 3 times more likely to die after childbirth? And the answer was, they think that we are strong and can handle whatever is going on. Others also look at you and think that you are strong. And the one below, it could be because they don't know anything about health issues during their pregnancy, or it could be like the doctor wasn't paying attention to the meter to see exactly what's going on with the baby or the mommy, because I know they put all that stuff on you, and some people wouldn't know they have health issues until the situation happens. Next slide, please. And so I asked them to describe what would be the ideal health provider. We wanted to know, what can we do? What would make things better for your healthcare experience? And I like here, they care. You can feel when someone is genuine and has your best interest at heart. Someone who likes what they're doing, lets you ask all the questions you want, not just someone there to get paid. And you need a relationship. Next slide, please. And I had to highlight all of this because I asked, what would make you not want to go back to a care provider? And of these samples I have, they treat me like a check. I'm just a dollar sign to you. tone, the way they act, they really don't want to be bothered. The doctor is not here. They're in the room, but they're on their phone, not present. I have been called by the wrong name. I'm going to mention that again a little later, but it was certain things they say, like, I felt like they were being rude. Like at first, I did come up with a little something down there, and he was being ugly and making me feel uncomfortable. And I didn't want to hate myself about what the situation was, but I didn't take charge myself. I told my mom, and my mom handled it. She told them it was an issue. She said that she may not have said it to you, but she mentioned it to me. So she was complaining about how the physician treated her during her exam. Next slide, please. And how would you describe respectful care? And I'm going to mention the first one. Be focused on the patient when you go in the room. Be present, as I said. Having a provider that doesn't respect you is like being in a bad relationship. And highlighted here is respect for what you say and honoring your request. Next slide, please. And what's the best way to get information to moms? Because we're talking about helping them to be able to identify when they have warning signs or high-risk factors. And one of the comments I thought was pretty important was don't overload us with big packets. Make it fun, use colors, and don't overwhelm us. Use technology, keep their attention engaged. And women will recruit friends if it's fun and interesting. Women are more caring, and they have been through similar experiences, and they're saying that they can share. Women will talk among themselves if they get information in a manner that they can accept it and understand it. And this last one, unfortunately, said healthcare providers look at low-income people different. They treat us different. If you're paying, they give you whatever you want. You can tell who has real insurance, the good insurance, and who doesn't based on what you hear being said to patients. Okay, next slide, please. So just kind of a summary of the responses from the mothers are, first, we found that the things from the mother was, one, that their health care needs and concerns were often not given primacy by their providers. And this is the slide that the comment that I made earlier. Yeah, they don't look at you. I've had doctors come in, open the door, call me someone's name, like, oh, I'm sorry, and checking their phones. I'm here because I have issues I'm really dealing with, or I'm concerned about stuff, and you aren't even here with me in the room. You're physically here, but you aren't mentally here with me. Like, what are we doing here? Then the second one is that risk was situated at the level of the individual woman, implicating individual behaviors rather than societal structures that can cause disparate outcomes. So they said, like, well, it's the poor diet, or women don't listen, they go out too soon, they don't take care of themselves, they don't know what their family health, they don't know their family health history, and they're trying to be that strong Black woman, not sharing their problems, and too much stress, situating it again at the level of the woman. And then that respectful care can be achieved through specifically described collaborative interactions. In this moment, make me feel like I am your only patient. Be present. Treat me like family. Make me feel wanted. Make my concerns your concerns. Answer my questions. Be kind and caring. Don't judge me by how I look. Don't act rushed. Ask, what can I do? Show me that I matter. Next slide, please. And then, so the preliminary findings from this study indicate that a high rate of maternal mortality and severe morbidity in African American women could be mitigated with the introduction of respectful care procedures when their design and construction is informed by women directly impacted by the abiding inequitable practices. So now we have a new project underway to build on the findings from the interrogation of the qualitative data that was collected in this study. The aims are to identify facilitators and barriers for mitigating the impact of implicit racism on African American women in the healthcare setting, and to develop strategies that will optimize utilization and effective healthcare services for African American women. Next slide, please. And I'm just saying thank you to all the people who participated in this particular study with the IHI Merck for Mothers and the Henry Ford Health System, Greater Detroit Area Health Council, Michigan State University ECHO Project. And I have a few slides from another presentation, this next presentation, Brianna.
Yep, I'll pull them up. Just one second.
Thank you.
Yeah. Okay, Dr. Norman, do you want me to click on a specific slide or just kind of
start from the beginning?
Okay.
Do a regular slideshow.
Yep.
Okay, so this is the name of this project. Jean Curver works Dr. Curver works very diligently with me to help to get in a proposal back in June of this year in response to a request from NIH. And the study is called Mitigating the Impact of Implicit Bias on Maternal Morbidity and Mortality for African American Women. And I've been telling you about things that women say, but I wanted to give a face to the what actually happens to families in their lives in maternal mortality. So I have next slide, please. So this is Kira Dixon Johnson, who was 39. She died in April of 2016 after bleeding internally for more than 10 hours following a routine C-section. She left behind a husband and 2 sons. And her husband, Charles Johnson, has been speaking nationally about what happened because he repeatedly went and requested help, saying there was something wrong with his wife. It was not responded to in an immediate in an appropriate manner. And he has developed an organization called For Kira, for Moms in Atlanta, Georgia. Next slide. This is Amber Rose Isaac. She was 26 and she died on April 21st of this year after an emergency C-section. She had tweeted on April 17th about her negative experience at Montefiore Medical Center in the Bronx. And her partner has developed the Save a Rose Foundation as a result of her death. Next slide, please. This is Yolanda Shifra Kadima. She was 35. She died July 27, 3 days after a C-section delivery of her twins. She leaves behind 7 children, including her newborn twins. And again, and again, her family is following up in her memory to stop this the unnecessary death of African American women. Next slide, please. And so, just continuing, the tragedies continue. The members of the medical community at Indiana University School of Medicine mourning the death of Shanice Wallace. She was a fourth year pediatric chief resident, and around 35 weeks into her pregnancy, Wallace developed symptoms of preeclampsia. Her baby was delivered by C-section, but Wallace had subsequent complications, including a ruptured liver, kidney function issues, and high blood pressure that required additional surgery. She died on October 24th, 4 days after her daughter, Charlotte, was born. Next slide, please. And this is Shanice Wallace, who died in October of this year. She was a physician, well-versed, knew what she was supposed to do, took care of her health, and yet she is gone. Next slide, please. So just to tell you about the supplement real quickly, just in a minute, about 700 women die each other from conditions related to pregnancy and childbirth. We have the highest rate among developed nations, and it's estimated 50,000 experience severe maternal morbidity. So there is a new initiative called Implementing a Maternal Health and Pregnancy Outcomes Vision for Improve. And NIH was asking for proposals to address severe morbidity and mortality from a community aspect, and that's why we submitted this proposal, and that's why we're participating in it now. Next slide, please. And so the hypothesis is that if we elicit guidance from community stakeholders through the lens of reproductive justice, respectful care, and health equity, we can offer critically important information useful in reducing disparities in maternal health and perinatal outcomes. Next slide, please. And the goal of the study is to conduct community-based participatory research to identify interventions to reduce the impact of bias in healthcare that may contribute to increased risk for maternal mortality and morbidity in high-risk populations. Therefore, this study is going to engage African American mothers, community maternal health advocacy organizations, and healthcare providers in a series of structured interviews and focus groups. And utilizing a mixed method approach and doing content analysis, the data obtained will be used to develop a toolkit of specific strategies for mothers to counter negative interactions and obtain patient-centered, respectful care. And I'm going to stop here so we have questions or anything that I can add, let me know. But I did want to let you know that I also work with the My Aim Alliance for Innovation in Maternal Health here in Michigan, which is an organization that specifically is addressing severe maternal morbidity and mortality from the hospital side. So there are bundles that are required that hospitals implement for sepsis and hypertension and hemorrhage. and working with the hospitals throughout the state that are supposed to be doing this and submitting the data is the other aspect. I'm looking at the clinical side, then therefore, and I'm looking at the side of the mothers and talking with them from the